Great. Thank you very much for inviting me to speak. This is quite a dry topic, so I apologize in advance, but I'm talking about bone substitutes in trauma. So we all know that bone grafting has an established, it's really the gold standard for trauma. You know, you've got the advantage of having cells and the biological mediators you need for healing. And some of the evidence suggests that actually the size of the defect when you bone graft doesn't actually correlate with bone healing, which is interesting. One of the problems, though, is that you've got the morbidity associated with taking bone graft, the increased operative time, blood loss, and potentially limited stock of bone to actually use. So it does call into question whether we can use bone substitutes for this purpose. Obviously, it mitigates the morbidity. You don't have to take it from the patient. Potentially, you can support chondral areas, particularly in periarticular fractures. And there's also potential use for drug delivery, either antibiotics or mediators to help in bone healing. But there is a cost. The evidence is not great, and you have got a foreign material. So there's an issue related to wound leak and the potential for a foreign body that can cause problems in the future. When we look at an ideal substitute, we want something that's inert, we want something that will potentially resorb so that you don't have to go back in and remove it later, and potentially offer mechanical stability. And although this is always talked about, you know, the mechanical properties of substitutes, it's probably quite misleading because a lot of these absorbable materials will have no inherent strength as they dissolve. So, you know, when we're told about the mechanical properties of these materials, we have to take that with a pinch of salt. But ideally, you want something that's osteoconductive to allow bone formation and remodeling of the bone. But there is a real breadth and a bewildering range of products available. So it's quite difficult to know where to start. We've got pastes, we've got pellets, we've got blocks, we've got chips, and every company has their own make and model. Essentially, there are various options. So in this talk, I'm going to focus mainly on the material rather than the stuff in the material. So you can obviously, lots of people add different chemicals or biological mediators to try and support healing. But we're going to talk predominantly about the ceramic-based substitutes. So that's calcium sulfate, that's calcium phosphates, and we'll look at those. So there are some polymers that are used, and they can be dissolving or not dissolving, but really we're going to look at the ceramics. The most common ceramic we use in orthopedic practice is calcium phosphate, and it's often an injectable material. It has lots of different types. Hydroxyapatite is a calcium phosphate, so they're just different types, that all minerals in bone, but they are metabolized differently. The key thing about hydroxyapatite is it requires active cellular metabolism to remodel it and to break it down. So if there's no blood supply, it will stay there forever. So calcium sulfate is the most commonly used material. It's often used in isolation, but it's often added to other materials to make them what we call biphasic. So the calcium sulfate dissolves quickly with the idea that you leave behind a scaffold of some longer acting material that will allow more bone ingrowth. It's cheap, but it dissolves quickly, as I said, and that's associated with problems with wounds. So it tends to leak, and it's got very poor compressive strength. So when you put it in, it very quickly dissolves, and it doesn't really offer any support to the bone. If you look at the various materials about how quickly they resorb, you'll notice there's quite a big difference in how quickly they go. And the problem really, it's like the Goldilocks problem. You want to get it just right. If it's too quick, then there's not enough time for bone to form, and you'll end up with voids. If it's too slow, then you don't get bone formation, and that potentially can sit around for a long time and cause problems. And for some of these sintered products where they heat them to high temperatures, like the chips, they often can last extremely long time. So, you know, the half-life, if you like, can be many, many years. So this is an example of a case where we've used calcium sulfate. So it's pellets, but you can see that the cavity is filled very quickly. Within the first 6 weeks, it dissolves. And the problem then is you end up with a void, which is just a void, and it doesn't change, so that void remains. If you look at some of the products like the calcium phosphates, where we have injectable composites usually used for plateau fractures, they do hang around for a long time. And you know, we're told that they disappear over the first 6 months to 18 months. But in reality, they often hang around for a long period of time. Now, that may not be a problem, but occasionally it is. And this is a case of a guy who had a fracture who had the material there for a long time and subsequently developed an infection. And one of the big problems is once these implants get infected, they're very difficult to remove. So that's something to bear in mind. Obviously, we're all familiar with the biological concept, the diamond concept. And you know, when you're thinking about replacing bone, you want to have this in mind, that it's not just about the material. You have to provide an environment for the bone to heal properly. And the guys out of Leeds have done a lot of work on this. You might argue that there are other ways of achieving this environment. And you know, it may well be that actually, rather than filling a void, the best form of the diamond concept is host bone. So if you can get vascularized alive bone into a void, then actually you get all those things and a significant resistance to infection because the bone's alive and healthy. So what's the evidence? Well, the evidence is a bit shaky. So if we look at tibial plateaus as a starter, so there's been a review in 2013. I think you'll know that, Nick. Essentially, this is looking at the different materials. The problem is it's quite difficult to draw much from them. Most of these patients do very well, whatever happens. So a lot of them heal anyway. Interestingly, they found no correlation between the degree of resorption or bone healing and outcome. So it seems that as long as the bone heals, you don't necessarily have to worry about the void filling. What they noticed is that the subchondral collapse was more common with the calcium sulfate materials, because again, I think it hangs around for a very short time, doesn't allow bone formation to take over. So the calcium phosphates support the collapse better, but of course there's the issue of them being around for a long time. But it did seem to suggest that it was associated with shorter surgery, improved weight bearing, better early function for patients. There's a more recent randomized trial looking at tibial plateau fractures where they've used a particular biphasic product. It was a multi-center study, reasonable dropout rates, lost to follow-up, but that showed that there was really no difference between bone grafting and a bone substitute, this particular bone substitute, which was Cerament. So the functional scores were good, and again, you've got the benefit of reduced blood loss, reduced operative times, and less pain. But of course, you know, you could argue that some of these fractures here, do we really need to use bone substitutes? They might do quite well without them. The key message really is that if you want bone healing, you need vascularization. And the problem with the cement or the ceramic carriers is that they rely on this vascularization for the bone cells to get to the area to heal. So they have to heal from the periphery to the center. And often, the major issue is the lack of the blood supply. That's the limiting factor. So there's an argument you need good bone contact with the native bone, with the material, to actually allow that to happen. Because this happens by intramembranous ossification. It's not cartilage. It needs to be in contact with the bone. So when you think about the cases where you might use bone substitutes, they tend to be those bone loss fractures, high-energy injuries, people with osteoporotic bone. And actually, if you look at that, that's the high-risk group. These are the people that are likely to get problems. So one of the things you might have to think about is if you're using these carriers, should we be protecting the carriers by using antibiotics? So adding local antibiotics to the carrier. Because what you don't want is an open fracture that has this carrier put in that then gets an infection. It becomes very difficult to manage. And we know that there's some evidence suggesting that there's good activity of local antibiotics at minimizing risk. So prophylactically, these are old studies looking at PMMA spaces, but you can see that there is a significant risk reduction in fracture-related infection with local antibiotics. So in summary, bone substitutes have a role in trauma. They may reduce the morbidity associated with bone grafting, but it's important to choose our material wisely and then consider how we can minimize the risk of complications like infection from using them in these bigger defects.